Good evening, everyone. So I'm Kathleen Diggory. I'm a distinguished professor of neurology, and this is Headache School tonight. And we're going to be talking about new daily persistent headache. I want to try to cover what it is and what you should do about it. And we are so glad to have you here at Headache School tonight. So I'm going to start with a case, and this is sort of based on a case that I did see several years ago. It was a 20-year-old man, and he has a mother with headaches. His life history is he was never car sick. He didn't have stomach aches as a child. He'd get an occasional dull ache in high school, usually when he got dehydrated, but he wasn't light sensitive. He wasn't sound sensitive at all. So he went on vacation to Hawaii, nice place to go to, and he woke up with a headache. It was sharp, it was on the right side. He did have sound sensitivity, not much light sensitivity, no nausea. And it went on for about 2 weeks. And he just took some acetaminophen and butalbital and from urgent care, and it didn't help. He had a headache was worse on the plane back to Salt Lake City, and it was finally gone in a month. And he was so happy that it was all resolved. But on October, so this would have been June to October, 4 months later, he developed another headache, and this headache has never gone away. It's sharp, pounding, bilateral. It can last an hour very severely. He has no light or sound sensitivity or nausea, but it does get worse with activity. And about 3 times a week, it worsens into a severe headache, and that's when he gets light sensitive, sound sensitive, and it can last all day. In between, however, he has a constant dull ache all the time without those migraine features. He's a student, and he's a good student. And he went to see a doctor and a neurologist, and his MR scan was normal, and he had normal blood workup. So what's going on with him? He has a daily headache, and the daily headache is without migraine features, meaning he hasn't got light sensitivity, sound sensitivity. And what's peculiar about this headache is he remembers the date it started, October 9th. And then 3 times a week, he gets a really bad headache. And that one sounds like migraine. He has light sensitivity, sound sensitivity, and no nausea, but it sounds like migraine is what he's got. And this is a typical, what we call new daily persistent headache. And what it is a daily headache that starts at one point in time. And often there's no preceding headache history. And it's usually not attributable to another cause. And this, as you will see, is extremely important. And in the headache world, we classify new daily persistent headache with a definition from the International Classification of Headache Disorders. And they describe it as a persistent headache, daily from onset, clearly remembered, and the pain sometimes lacks characteristic features. It can sound migraine-like, it can sound tension-like, or it can have elements of both. And the diagnostic criteria are a persistent headache with a distinct and clearly remembered onset, with the pain becoming continuous and unremitting within 24 hours. And it has to be present for over 3 months. And of course, it's not caused by something else. And in this disorder, you always have to consider something that could cause it, as you will see. Now, this graph looks confusing, but if you can see my pointer, I'm going to just take you through this graph, which is a wonderful paper by Dr. Matthew Robbins in New York. a colleague of mine, and he is a real expert in new daily persistent headache. But as you can see on this graph, on the lower part of the graph, it says episodic migraine or tension type headache, and it progresses in the setting of risk factors like increasing age, female sex, low socioeconomic status, stressful life event, head trauma, high basal attack frequency, medication overuse, caffeine overuse, obesity, snoring, and sleep apnea, pain disorders, anxiety, depression, allodynia, meaning that if you touch your skin, it should not normally be painful, but if it is, it's a risk factor for progression into chronic migraine or chronic tension type headache, asthma, ineffective acute treatment, and persistent nausea. And you can see that people can get chronic migraines with all these risk factors. They can get chronic migraine. But look at the difference. New daily persistent headache starts at time 0, goes all the way up here, and stays here every single day, abrupt onset, and it doesn't go away. So you can kind of see the difference between these two types of chronic daily headache. Now, there are many mimics to new daily persistent headache, and this is where your neurologist, your caregiver, your provider really has to be careful. They have to look for high pressure or low pressure, and I'm going to show you a case of that, and check the imaging. They have to look for thrombosis or a stroke in the veins, and you can see that usually on imaging. They have to look for dissections of the carotid or the vertebral arteries. This also is present on imaging. They have to look for other vascular constriction syndromes, giant cell arteritis, which is a blood test for people who are over 65 or 70. Sometimes they have to look for meningitis, like a fever, and you may need a spinal tap. Sometimes sphenoid sinus disease, and you'd see this on imaging. This is a sinus that's deep in the head and can give really bad headaches. Sometimes cervical spinal hypermobility or facet arthropathy, so something wrong in the cervical spine, and then, of course, tumors. So these are things that a provider, if you have new daily persistent headache, they have to really look for secondary causes of this new headache. So here is a case of a person with high pressure. They often will have findings of extra fluid, spinal fluid around their optic nerves, and even may show papilledema, so they can actually look in the eye and see that there's swelling. And then they developed an emptyselia and so on and so forth. Or low pressure, and here you can see a real big difference. The pituitary gland is enlarged, the whole brainstem is slumping, and then when they do the gadolinium or the dye with the MRI scan, you see this smooth enhancement inferiorly on that picture. And low intracranial pressure, or sometimes what we call intracranial hypotension, is associated with people who have hypermobility of their joints. Now, not everybody has that, but you can see this lady on the left is able to touch the floor easily with her leg straight. And when she straightens her leg, it's almost as if her knee goes backwards. Normally, as we stand, our knees are in front, but sometimes people get this sort of straightening of their knee. And if they extend their arm, instead of it just being flat like this, it actually extends so that there's some hypermobility, and you can see that happening. The fingers you can see fingers curling way up, or somebody's able to touch their thumb to their wrist, or sometimes they're able to do various postures, especially lying on the floor with their knees back, or again, showing how arms going back are hyperextended. This is a hypermobility syndrome, and people who have this syndrome are a little bit higher risk for this intracranial hypotension. And a doctor should really look carefully to see if there is hypermobility. And there's a score called a Beighton score, and you can get points for being able to put your thumb to your forearm. If you hyperextend your little finger and you can go way, way back, or your elbow goes the opposite way, or your knee goes the opposite way, or you put your hands on the floor. And then you get credit for all of these. You get credit. You count up all the things that people have. And if you've got a score of 4 out of 9 or more, you would want to make sure your provider really looks for this hypermobility and looks for intracranial hypotension. And we look for specific imaging findings. I just showed you a brain of somebody with low pressure with the sagging brain and everything. But they also may need to look for the cervical spine where they have an abnormal extension, abnormal flexion, and instability of the cervical joint. So these are things that a provider is going to look for in imaging. But there are other causes. Remember, I told you that you can have arterial dissection, and this can be seen on an MRI scan, or you can see it on an angiogram, but usually an MRI scan is where we start. Venous sinus thrombosis, when you get a clot in your vein, you can start having a new daily persistent headache. It's another thing we look for. And so if you have new daily persistent headache, what should you expect your provider to do? 1, a careful history. Very careful history, thinking about everything, okay? A careful examination. I just told you that there's a lot of things to look for and that a person should really have a careful exam. An MRI scan with contrast should be done to rule out that low pressure syndrome, which is a very common cause of new daily persistent headache, or another cause. And I just showed you some examples. If you've had fever or if there's any signs of infection, your provider may want a lumbar puncture to look at your cerebral spinal fluid, or what we call CSF, to make sure there's no infection. Your provider may also get more blood work to look for a thyroid, to look for inflammatory causes, to look for other things. And your provider may get other studies as well, okay? But expect, if you're going in for a new daily persistent headache the first time you go in, you may need more workup, okay? You should expect it because this is not a diagnosis you just flippantly make and say you're done. Now, let's talk about new daily persistent headache. Almost all people who have this type of headache, 50 to 82% of them say pinpoint the date, just like my patient. October 9th, this headache started and it's never gone away. The provider has to think about every secondary cause. I just told you that. Sometimes there's a trigger, and we're going to talk more about triggers, but let's say you've had a flu. After a flu-like illness, sometimes people can get this headache. Epstein-Barr virus, EBV, herpes simplex virus, cytomegalovirus are viruses that seem to go with new daily persistent headache. And I'm going to talk a little bit more about that. Minor head trauma, a slight bonk on the head, no big deal. But from that day forward, you had a daily headache that never went away. Here's a peculiar one, a surgery. Somebody had a surgery. Sometimes it's with intubation and you get hyperextended on your neck to get the breathing tube down your throat. But sometimes it's not. It's like you had surgery on your leg and you wake up from the surgery and you have a daily headache. And nobody really quite understands that. Another one that I see frequently and I ask about is closely spaced stressful life events. My father died. My kid got in an accident. My other kid is in jail. My life is out of control. And, closely spaced, stressful life events. Hormonal manipulation. Sometimes women who get put on hormones, exogenous hormones, can start having new daily persistent headaches. And you really have to look for one of these. And sometimes vaccination rarely can give you new daily persistent headache. Now, this is not a common disorder. Its prevalence, meaning how prevalent is it in our population? It's way less than 1% of our population. It's 0.1%. But in the general population, if you take all people with chronic daily headache, it accounts for about 2%. It means like 2 out of 100 people will have new daily persistent headache. In my clinic, however, if I get all my daily headache people together, it's 10% or 11%. That means like 10 to 11 out of 100 will have this diagnosis of new daily persistent headache. Now, the onset can be any age. And you can see in this graph over here, women are in black, men are on these little white lines here. But you can see how it occurs almost at any age, but often 30 to 50. If you take all of these people, that makes up the majority of them. It's much less common as people get older, but it's in this age group that is very common. Children can have it. Look at this, 11 to 20 years old, people who have new daily persistent headache. And adults with daily headache can have it. Some people believe that it's more common in men than women, but look at this graph. It was more common in women than men. It occurs in both. And there are many comorbidities. Now, comorbidity means what can come with it when it's just new daily persistent headache. Depression, 60 to 90% of the time. Anxiety, 50 to 90% of the time. Well, if you've got a daily headache and it's really interfering with your life, you can understand where you might have some anxiety. And even panic disorder can occur in this new daily persistent headache. I mentioned the triggers, and I'm going to talk a little bit more of it. Infection or flu-like illnesses occurs in almost a third of people. So 1 out of 3 people may have had a flu-like illness that started this off. And then I talked about stressful life events, extracranial surgeries can occur up to 10%. Some kind of athletic activity, that's why you really have to rule out that intracranial hypertension. Childbirth has been associated with new daily persistent headache. Onset of menarche for young girls. Vaccination I talked about. Sometimes medications can start a new daily persistent headache. I talked about estrogen, exogenous estrogen, but other medications may do it too. And coming off antidepressants sometimes can cause a new daily persistent headache. So the question you're going to ask me is, well, what about this virus thing? So Epstein-Barr virus, this is the virus mononucleosis. You've heard the kissing disease mono. This virus is actually the antibodies to this virus are present in almost 85% of people with new daily persistent headache. So that's why people wonder if this is a viral triggered condition. And if you take controls that don't have new daily persistent headache, their Epstein-Barr virus is present in a quarter of the people, or 25%, so 1 out of 4. And so many people have studied this, but having had a previous Epstein-Barr virus is associated with new daily persistent headache. But look at this. Herpes simplex, the one that gives you the cold sores on your mouth, cytomegalovirus, another virus, and then COVID. COVID has triggered new daily persistent headache in almost 20% of people who've had COVID. And it can be long COVID, but it can just be new daily persistent headache after COVID. And then a rising condition is called dengue fever. It's spread by mosquitoes. And this is actually rising in our country, especially in the South and the East Coast. So it's something to be aware of. What else could cause new daily persistent headache? Endocrine problems like hypothyroidism. So that is why your doctor may get blood studies to look for endocrine problems. And then, of course, as we talked about, this low pressure syndrome, which we discussed. Now, what I think is interesting is that migraine has been reported to have an abrupt onset in about 30% of people. So no other cause, but see, this is abrupt onset of chronic migraine. I put it in red. So 30% in this series, one out of three had um, uh, a migraine kind of start abruptly and never go away. And the phenotype of the headache, it can be migraine, but other headache phenotypes can do this too, like hemicrania continua, which is a continuous headache on one side of the head with some autonomic features, and of course, tension type headache too. And what's interesting also is that some investigators have found that it comes in seasons like September, November, March, April, kind of the spring and the fall. And there's somewhat of a seasonality to it for some people. Now, here's the bugaboo about this condition. There's little data on how to manage new daily persistent headache. And the current strategy, of course, is to make the diagnosis, make sure there's not a secondary cause. And if there's not a secondary cause, the diagnosis is new daily persistent headache. There's not a secondary cause. The strategy is to treat the dominant type. So if it's kind of a migraine with light sensitivity, sound sensitivity, nausea, we treat it like a migraine. If it's kind of like a tension type headache, a real tight squeezing band-like headache, it doesn't get worse with activity, it may get better with activity, and there's no nausea, there's no light and sound sensitivity, that kind of stuff, that's more like a tension type headache. The other bugaboo about this headache is it's often refractory to medication. So your doctor may be trying a lot of different things, and we'll talk about what those things could be. And if it's a migraine, your provider is going to try to treat the migraine piece of this. There are some case reports about using an antibiotic called oral doxycycline, which can inhibit a TNF alpha. You don't need to know that, except that this antibiotic that's specific, doxycycline, sometimes treats this. Mexiletine, which is another kind of weird medication that we don't use very often, and nerve blocks. Those are where case reports show that they may be helpful. Now, we divide treatment into acute, like what am I going to do if I get a really bad headache? I've got a new daily persistent headache all the time. But what do I do if I'm getting a migraine on top of this? Well, we use triptans, and I'm sure you're aware of sumatriptan, rizatriptan, naratriptan, elatriptan, zolmitriptan, elmotriptan, frovatriptan. And about 1 in 3 people will respond to a triptan as an acute treatment. Now we also have gepants like rimegepant, ubrogepant, zavegepant, and these gepants can also treat headache, but there's not a lot of study on new daily persistent headache on the gepants. There's another drug called lasmiditan, which is a ditan. It's like a triptan, but it works on a different receptor. And then nonsteroidal anti-inflammatories like naproxen, ibuprofen, diclofenac, and others. Sometimes ergotamine is used. Sometimes isometheptine or midrin is used. Nerve blocks seem to be very helpful in some series, up to 60%. So over half the people who get a nerve block can get improvement. Now, there are many devices also that have been tried, and a lot of people like things that are not medication. So the supraorbital nerve stimulator, this is a device that's put on the forehead, and it's like a TENS unit on the forehead. You can do 20 minutes a day for prevention, and then there's an acute setting as well. Transmagnetic stimulation, sometimes called the SAVI device, has been used. Vagal nerve stimulator, where you stimulate the vagus nerve acutely or even preventatively. And then there's this new device of a superior orbital, but also an occipital nerve stimulator at the same time. And then there's this transcutaneous nerve stimulator, sometimes called the Nerivio device. And then some old standbys that I like, the ice hat. An ice hat is great because you can tighten this up on your head and then put ice in it. And for some people, this works great. FL41 tint. If there's a lot of light sensitivity, people really respond to that, and you can get that in an optical shop. And then what we call the Allay lamp or green light therapy has been shown to be helpful for migraine. Okay, so acute treatment, medications, devices, an ice cap. Then you've got how do we prevent new daily persistent headache? And I'm going to tell you it's difficult. Your provider may have to try multiple different medications to find one that makes a dent in this headache. And I talked to you about doxycycline, another drug that sometimes is used as montelukast, mexiletine. Occasionally, people have tried prednisone. And then typical migraine medicines like the tricyclics, amitriptyline, nortriptyline often help with sleep because some people have a sleep disorder that comes with this as well. Anticonvulsants like topiramate, valproate, gabapentin are also tried. In some people, they work. SSRI or serotonin, selective serotonin reuptake inhibitors like fluoxetine or Prozac, citalopram, or Celexa. SNRI like venlafaxine or Effexor, beta blockers, calcium channel blockers. Now, CGRP monoclonal antibodies are a new kid on the block as far as treatment. They're monthly injections, and that has been reported to be helpful in new daily persistent headache. And some of the Gepants also prevent, like every other day rimegepant or atogepant. And then there are devices, the ones I showed you. Onabotulinum toxin has also been shown to be helpful in new daily persistent headache. And one thing that we shouldn't forget is cognitive behavioral therapy, which in some series has worked as well as medication, daily medication use. So I always recommend that because it does really, really help to get some control over this headache. Now, you may want to say, well, what happens to a person with new daily persistent headache? And I'm going to show you different approaches to understanding prognosis. One investigator said there's two forms. One is self-limited, 80% headache-free in 2 years. So if you have new daily persistent headache in this series, in 2 years, about 80%, 8 out of 10 people would be headache-free. However, there is a group of people who get a protracted refractory, and it's refractory to a lot of different medications for years. And in that study, if you were going to remit, you were going to remit within 2 years. Remit means to go away. But others have had different reports, like this Van report said 68% would be headache-free in 6 months, 80% at 12 months, 86% at 24 months. And others have pointed out that persistent, and that's new daily persistent headache, are usually seen in younger, and they often have depression or anxiety. There is a remitting form that goes away, and then there's a relapsing and remitting form. Now, remember, my patient had a couple weeks of a daily headache that went away. It didn't last 3 months, so it didn't meet criteria, but there is a relapsing remitting one as well. And so, there are other studies that show that maybe there's resolution in 1 out of 3. So the problem with this headache is it is hard to treat, and you just have to keep working to come up with something that can bring it down so you can live your life and keep on going. So what did we do with our patient? Well, first of all, we spent time empowering our patient to say, okay, we're in this together. We are going to get you back to school. We're going to get you under control. We started some amitriptyline so that he could sleep at night. He came off the propranolol because it was making him have low blood pressure. We discussed maybe going on gabapentin for pain dysregulation, starting at a very low dose and slowly working up. And we talked about neuromodulation for prevention. We gave him sumatriptan for those migraine-like headaches, and another option was niratriptan because it had a little longer onset of action. And then we talked to him about occipital nerve blocks. And he actually did better. He slowly got better, but it took a long time. So New daily persistent headache. The first that point I want to make is your provider has to make the correct diagnosis. And that means rule out, make sure there's no secondary cause of it. But if there's no secondary cause, it's this new daily persistent headache. Look for a triggering event. It may or may not occur, but we look for it. Treat the migraine portion because we can treat it. We've got medications that can treat it. And then just be aware that these are very hard to treat. And it really behooves you to have a close relationship with your provider, be it a primary care provider, a neurology provider, a headache specialist, but you are going to need to make a real connection so that you can work together on this headache type. The American Migraine Foundation has wonderful handouts on new daily persistent headache. And you can just click on these and just put in the search button, new daily persistent headache, and up pops some very nice handouts that you can look at for later.